بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we continue with gastrointestinal imaging, and this is the last lecture in the domain of GIT diagnosis, and we have dealt before with the imaging of the esophagus, imaging of the stomach, and imaging of the small bowel. Now we are going to discuss the imaging of the large intestine or the colon. And you know that the popular examination of the colon is via the barium enema, and this was the traditional examination done in the previous days, and maybe still be used in the clinical practice because of its valuable diagnostic effect. By this examination, we used to inject some of the barium fluid preparation through the anal canal into the colon, and we usually add some of the air following injection of the barium in order to have this beautiful image of the colon, which is known as the double contrast barium enema. And here you can see considerable distension of the colon with air and adequate delineation of the colonic segments by barium in the same time, enabling the radiologist to see mucosal lesions together with filling defects as well as strictures in the meantime. And this is the normal appearance of the what is known as double contrast barium enema, showing the descending colon, the transverse colon, and the ascending colon as well. Then what are the colonic pathology that we are going to discuss? And we have a lot of lesions in the colon, starting as usual by the diverticular disease, followed by inflammation of the diverticuli, colonic diverticulitis, then epiploic appendicitis, acute appendicitis, pseudomembranous colitis, neutropenic enterocolitis, ulcerative colitis, Crohn's disease, ischemic colitis, then the neoplastic lesions, starting by the benign polyps, then colonic malignancies, and finally we will end by the sigmoid and the cecal valvulus. You know that the colonic diverticulosis is a very common disease, and it usually affects the old population, and it is estimated that at the age of 40 years, about 5% of population will have diverticuli, and this incidence increased tremendously at the age of 80 years, and it may reach about 65% of the individuals. Colonic diverticuli are usually of the fourth type, and they are commonly affecting the left side of the colon, especially the sigmoid area. And right-sided diverticuli are usually rare and may be found in about 15% of the cases. Most of the diverticuli are small, but some of them may reach a large size. This is a barium enema showing nicely the distribution of some of the colonic diverticuli, and the diverticuli here are numerous in the transverse colon compared to few diverticular outpouching in the descending colon. And this is a good example for a double contrast barium enema showing numerous diverticular outpouching filled with barium as well as air, heavily located in the region of the sigmoid colon and the descending colon as well. This is also a good example of diverticular disease of the colon affecting the left side. Most of the diverticuli are filled with barium, and some of them contain air. This is uncomplicated diverticular disease of the colon. And the CT scan as well as MRI can diagnose colonic diverticulosis, and this is an easy procedure. If you look to this CT scan, and you can see this is the sigmoid colon, and you can easily identify small buckets filled with air along the colonic wall, and this is diagnostic of diverticular disease of the colon. Also by MRI, and you know that air is black in the T1 and T2 weighted images because of the absence of hydrogen protons. Then you see multiple pockets, air-filled structures along the wall of the sigmoid colon, and here in the coronal image as well, diagnostic of diverticular disease. Then there are a lot of complications for this diverticular disease, starting by inflammation, diverticulitis, hemorrhage, perforation, and the formation of pericolic abscess. Then fistulous communication, commonly with the urinary bladder, but may occur with the vagina, with the small bowel, with the skin, and the rupture of diverticulum may lead to pneumoperitoneum, and rarely it may lead to generalized peritonitis. And you know that perforation of the diverticulae in the colon is usually slow, leading to localization of the inflammation adjacent to the colonic wall. Then it's rare to have pneumoperitoneum from rupture of the diverticulae, and also it's rare to have generalized peritonitis from rupture of the colonic diverticulae. Then a small bowel obstruction is rare if the rupture of the diverticulum may result from inflammation and adhesions, and of course the malignant predisposition is well known for this colonic diverticulosis. Hemorrhage is does not necessitate the presence of diverticulitis. Hemorrhage can occur from diverticular disease, and this hemorrhage is commonly seen from those diverticulae located in the right side of the colon. Then the patient may present by bleeding rectum, and this hemorrhage or the site of the bleeding can be localized by the nuclear medicine, or sometimes by selective angiography. And then the diverticulitis means inflammation of one or more of these diverticulae. They will result by left iliac fossa pain and tenderness. Most of the diverticulae are located in the left side of the colon. Sometimes you may palpate a small mass which represents the pericolic inflammation and abscess formation. Then the easiest way for the diagnosis of diverticulitis is through the CT scan, where you can see the affected segment of the colon has a relatively thick wall, and the pericolic fat is smudged or stranded by congestion and inflammation. Meanwhile, you should identify some of the diverticulae as buckets filled with air in the affected segment of the colon. Then by the barium enema, this is the difference between uncomplicated diverticular disease of the colon with colonic diverticulae, normal caliber of the colon, and preserved hostile pattern. While in cases of diverticulitis, you got some spasm of the colon, relative narrowing of the colonic lumen, irregularity of the colonic wall, and you still see some of the diverticulae which are filled with barium or barium and air. And this is diverticulitis by CT. This is the sigmoid colon. You see the marked thickening of the colonic wall. You see some pockets of the diverticulae in the wall of the affected colonic segment, and very importantly, you should see a stranding or smudging or reticulation of the pericolic fat. Then this is colonic diverticulitis by barium enema and CT scan. And you see by very minimal relative spasm of the left side of the colon, and few diverticuli are seen along the affected segment. Here you see significant increase in the wall thickness of the colon, and very important stranding of the pericolic fat planes. And some of the diverticuli may rupture, as I have said, resulting in the formation of pericolic abscess. And if you perform barium enema for these patients, you may see the spastic left side of the colon, few diverticuli or along the colonic wall, and you get barium outside the colon into the pericolic abscess, as you can see in this case. Also, diverticulitis may result in fistulous communication, commonly with the urinary bladder, and less commonly with other pelvic organs and even with the skin. And here is an example of diverticulitis with fistula tract connecting the colon to the vagina. And one of the common findings that are usually presented in the exams is you see in the patient with colonic diverticulosis and air inside the urinary bladder. Then you know that this air is coming from the colon as a sequelae of colonic vesicocolonic fistula, and this is usually the diagnosis. Then we came to one of the lesions specific for the colon, and we'll discuss this in details in the sector of peritoneal imaging, which is known as epibloic appendicitis. What is epibloic appendicitis? Is inflammation of the appendices epibloica. What are these appendices epibloica? They are fatty, small fatty projections along the wall of the colon. These projections are freely mobile, and they have their small own blood supply, and they cannot be seen normally unless the patient has fluid in the peritoneal cavity. Then if you see this ascites and you see this at the wall of the colon, and you see multiple fat containing projections arising from the colonic wall. And this is also a good presentation for appendages epibloica. This is fat, not air, protruding from the wall of the colon, and this is one of the appendages epibloica which is prominent, as you can see. And you remember, you cannot see these appendages normally unless the patient has ascites. And what happens if this appendages epibloica has been inflamed? You remember, because it is freely mobile, many times there is torsion, and this torsion will compromise the blood supply, resulting in acute inflammation. The most diagnostic criteria for this epibloic appendicitis is this ring. And you see this ring is formed of the thickened peritoneum along the wall of the appendages epibloica, and this intermediate zone represents the fat of the epibloica itself, and the central dot will represent the artery which has been occluded, or the feeding vessel. Then if you look carefully here, and you can see the three layers. The outer layer represents the second peritoneum, the middle layer represents the fat of the epibloica itself, and the central dot represents the artery. And of course, because this is an inflammation, you will see a stranding of the pericolic fat planes. And if healing occurs, you may see some dystrophic calcification at the site of the lesion. This is another example, and I have to say that diagnosis of appendages epibloica is difficult, and is usually the diagnosis of exclusion. And whenever you look for a patient with acute abdomen, searching for diverticulitis, appendicitis, cholecystitis, and so on, and you did not find any signs of these, and you may think of epibloic appendicitis, looking for this classic lesion, you may succeed to find one of these lesions. Then we came to the acute appendicitis, and you know that this is a disease which is common in the children and the young adults, and the clinical presentation is well known for all of you, which includes fever, nausea and vomiting, localized pain and tenderness to the right iliac fossa, and sometimes you got or many times you should have leukocytosis. Then the inflammation of the appendix will result when the appendix is obstructed, and obstruction is usually caused by lymphoid hyperplasia in around 60% of the cases, appendicolis, which is a calcified lesion in about 33% of the cases, foreign bodies in Crohn's disease, structural tumors like carcinoid tumor, and even parasites. Then the most common radiographic diagnostic criteria for the diagnosis of acute appendicitis by plain X-ray, by CT, and by ultrasound is the detection of this small calcified appendicolis in the right iliac fossa corresponding to the site of the appendix. And the appendicolis makes the possibility of acute appendicitis good in more than 90% of the cases. And this appendicolis is easily identified by ultrasound, and you see this is the appendix, which is dilated and the wall is thickened, and you see the appendicolis like a stone with posterior acoustic shadowing. Dilated appendix with lumen more than 6 millimeter in diameter is seen. There is no air inside the appendix, is obstructed, and you may see edema or fluid collection in the periappendical area. And this is the appearance by CT. You see the appendix is distended with fluid, the wall of the appendix is thickened, and you can identify the appendicolis as a calcified lesion at the neck of the appendix. Many times you see stranding of the pericolic fat planes, and sometimes you got abscess in the region of the appendix, especially if the appendix has ruptured. Then there are some cases where you can see the appendix is dilated and the wall is thickened and there is fluid inside the appendix, but you cannot see the appendicolis. And the appendicolis is not usually present in every case of acute appendicitis. And this is appendicular abscess after rupture of the or perforation of the appendix, and you see the criteria of an abscess formation: fluid collection with thickened enhanced margin and some internal air loculi, as well as the phlebolus or the appendicolis, which many times is responsible for the obstruction of the appendix. In cases of rupture or perforation of the appendix, the peritonitis is more likely than in cases of rupture of chronic diverticulitis, and the formation of abscess in the pericolic area is a good occurs in a good percentage of cases. And this is the appendicular abscess in the region of the appendix. This is relatively higher up, but you can see the inflamed enhanced wall and the stranding of the pericolic fat. Then we came to a lesion which is now seen commonly in the colon, which is known as the pseudo membranous colitis or Clostridium difficile colitis, because this is the bacteria responsible for this type of inflammation. And it is stated in the literature that this pattern of inflammation may affect the colon or the small bowel, but most of the cases are seen affecting the colon in particular. And the main underlying cause is the widespread of antibiotics, which will result in proliferation and growth of this particular type of bacteria, resulting in this pseudomembranous colitis. The patient may represent with diarrhea, abdominal pain, fever, and leukocytosis. This is very important. This leukocytosis is important. It will differentiate this type from in the another type. The history of recent antibiotic therapy is usually seen in most of the cases, and whenever this disease is advanced, it may lead to toxic megacolon, severe dilatation of the colon, which may end by perforation and death in some cases. Actually, it is not recommended to perform barium enema for patients suspected to have pseudomembranous colitis because of the risk of perforation. And you know, the colonic wall is inflamed and friable, and it may rupture. However, if barium enema is performed, and you may see nodular filling defects, but more important, you see significant mucosal thickening, as you can see here, and also you see appreciable thickening of the affected segment of the colon. And I have to say that this particular type of disease usually affects the entire colon. And this is the classic appearance of the pseudomembranous colitis in a coronal reconstructed CT image of the abdomen, where you can see a significant thickening of the wall, marked thickening of the colonic mucosa, and there are many of the signs that are mentioned in this particular appearance. Considering the target sign, if you look to the affected colon in the axial image, the accordion sign, and you can appreciate this here, pericolic fat stranding, and this is common for all types of inflammation. And you may see ascites in some cases. If you look carefully here, you can see some fluid in the pelvis as well. Then this is one of the serial images of the previous case, showing the classic appearance of pseudomembranous colitis. And you have to differentiate this from many other lesions which may produce mural thickening and mucosal edema, like ischemic colitis, Crohn's disease, typhlitis or neutropenic colitis, ulcerative colitis, and the diverticulitis. And we have mentioned this particular issue, and in order to diagnose diverticulitis, there should be some buckets of air filled divertically in the affected segment of the colon. And the diverticulitis is usually a localized disease to the left side of the colon, not affecting the entire colon as in this particular case. Then whenever we discuss these issues, you will know easily the difference. And here is the classic appearance of pseudomembranous colitis in the transverse colon, with thickening of the wall and the edema and thickening of the mucosa. Actually, the treatment is to stop this antibiotic, and you may have the help of flagyl as a supportive measure for the treatment of this Clostridium difficile organism. And pseudomembranous colitis is one of the lesions in the colon that produce thumb printing. And thumb printing is known in the ischemic colitis as well as in the pseudomembranous colitis. And some of the literature may say that you can reach the diagnosis from the plain X-ray of the abdomen, and if you have adequate clinical background. If you look carefully here, and you can see this part of the colon, there is a significant thickening of the wall with the edematous appearance of the hostra, giving the typical thumb printing. And if you look to the CT scan of the same case, and you can appreciate the typical appearance of this disease. And this is another case of a female patient with septic shock, and this suspected to be of possible GI origin, and she has also acute bloody diarrhea. And you see severe dilatation of the right side of the colon, and the typical appearance of mucosal thickening and the mural thickening with the stranding of the pericolic fat. This is also a classic appearance of pseudomembranous colitis, showing the previously mentioned data. And this is also, and you may, if you have this multi-detector CT and you reconstruct the images in the coronal planes, it's very helpful to see this typical appearance of pseudomembranous colitis. Then you came to the neutropenic enterocolitis, or what's known as typhlitis. This disease has, I think, three major criteria. Number one, it is seen in immunosuppressed patients. Number two, it is almost located to the area of the cecum and ascending colon. Number three, the patient had neutropenia, not leukocytosis. Then this disease affects the area of the cecum and ascending colon, commonly seen in immunosuppressed patients, as patients with AIDS and lymphoma, or those having organ transplantation and receiving immunosuppressive drugs. And it is worth to mention that the exact etiology and the mechanism of the disease is not well understood. And this is an example. If you see a lesion which is almost localized to the region of the cecum and the ascending colon, with a significant increase in the thickness of the wall, and of course a stranding of the varicolic fat, you may think of many of the pathologies. You may think of appendicitis, for example, and you may think of this typhlitis. And the helpful clinical data for the diagnosis of typhlitis will be the presence of severe neutropenia and the immune compromised status of the patient. And this is a case of typhlitis, and you see thickening in the region of the cecum and the ascending colon with the stranding of the varicolic fat, and this is a well-known immunosuppressed or immunocompromised individual. This is the same case you have seen before, and this is also another example, a lesion which is localized to the right side of the colon, especially the cecum. If you know from the clinical data that this patient is immune suppressed or immune compromised, and the leukocytic count is very low, like this absolute neutrophil count may be less than 500. Then these patients may present similar to other lesions like pseudomembranous colitis, for example, and diverticulitis by fever, watery or bloody diarrhea, and this is right-sided lesion will result in right lower quadrant abdominal pain. Mortality rate is high because of the bowel necrosis, perforation, and sepsis. This is a good example of typhlitis, and I have to mention that this diagnosis should be supported by the clinical finding of immune suppression and neutropenia. The differential diagnosis, as I have said, will include appendicitis and appendicular abscess, localized form of pseudomembranous colitis, lymphoma and leukemia, Crohn's disease, and ischemic colitis. And this is a case of testicular cancer with evident neutropenia, malaise, and fever. The CT scan of the abdomen shows localized thickening of the wall of the cecum with stranding of the varicolic fat. Of course, you know that in these inflammatory conditions, neutropenic enterocolitis and pseudomembranous colitis, as well as diverticulitis, barium enema, and also endoscopy are usually contraindicated. And the most reliable way for the diagnosis is the CT scan. Then you see cecal distension and wall thickening with fat stranding, and may result from paralytic ileus at this region with dilatation of the proximal bowel, pneumatosis and pneumoperitoneum, and varicolic fluid collection. Then we came to a well-known inflammatory disease of the colon, which is ulcerative colitis, and this is possibly an autoimmune disease predominantly affecting the mucosa, and this is the usual age of incidence of onset, about 20 to 40 years, and it may also seen in older patients. It has an equal male to female ratio, and this is the normal mucosa, of course, and the mucosa of the colon in cases of ulcerative colitis, and you see the severe damage of the mucosa. Then patients with ulcerative colitis may present by similar symptoms to the previously mentioned diseases like recurrent bloody diarrhea, electrolyte imbalance, and abdominal pain and fever. Then one of the criteria of this disease is exacerbation and remissions. This ulcerative colitis is associated with many of other lesions all over the body, and I will mention some of them like iritis, erythema nodosum, chronic active hepatitis, fatty liver, sclerosing cholangitis, spondylitis, arthritis, rheumatoid arthritis, and thrombotic complications. Then many of you remember this lead pipe appearance of the bowel, and by the development of ulcers and inflammation and fibrosis, you got effacement of the ostra, and the colon will be like the tube or the lead pipe with no ostra, and the wall is almost parallel to each other. And you know, this ulcerative colitis is particularly common in the left side of the colon, affecting the rectosigmoid area in about 95% of the cases. Affection of the terminal ileum may occur in about 5 to 10% of the cases with what is known as backwash ileitis, where the ileocecal valve is incompetent, and the inflammatory process will affect the terminal ileum as well. In the acute or the early stage of the disease, you may have a spasm and irritability of the colon, and you have fine ulcerations giving the well-known granularity of the mucosa. And this can be seen with double contrast barium enema, and you see fine loculi of barium throughout the mucosa of the colon, which represent minute ulcerations. And also, one of the famous findings in the acute phase is the presence of what's known as double tracking, where the ulcers are protruding beyond the colonic wall, and you get as if you have two walls of the affected segment of the colon. And thumbprinting is not a common appearance in cases of ulcerative colitis, but pseudopolyps are commonly seen, like in cases of Crohn's disease as well. Then this is considered in the era of barium enema as one of the diagnostic issues, which is widening of the pre-sacral space due to spasm of the rectum. This is the granular appearance of the colon and the rectum and the sigmoid area, and this is considered the final or the pre-final stage of ulcerative colitis, with lead pipe appearance, spastic colon, loss of ostra, and even shortening of the colon itself. Then in the subacute stage, you got coarse granular mucosa and inflammatory pseudopolyps. And these pseudopolyps are actually the hypertrophy or the prominence of the colonic mucosa to compensate for the function of the ulcerated mucosa, which are seen in Crohn's disease on similar basis. And here you see there is diffuse affection of the colon by ulcerative colitis. The colon has the pipe stem or the lead pipe appearance, and you can see these filling defects, which are known as pseudopolyps, due to hypertrophy of the normal mucosa to compensate the function of the diseased mucosa. In the chronic stage, you got shortening of the colon due to spasm and fibrosis, and the severe loss of the ostral pattern, and even you cannot see the pseudopolyps in this stage, And as I have said, backwash ileitis means that the ileocecal valve is widely open and the terminal ileum is involved by the disease. This is the case of ulcerative colitis, and showing the effacement of the chronic hostra on the left side of the colon with relative narrowing of the colonic lumen. The ulcerative colitis has to be differentiated from Crohn's disease, and this disease is usually affecting the terminal ileum and may extend into the right side of the colon, and then the skip lesions are one of the criteria. Familial bulbosis, there are true polyps throughout the colon with no inflammatory changes. Radiation ileitis, and there should be a history of radiation, and the affected bowel is still showing the hostra. Lymphoma is a diffuse disease affecting the wall of the colon. There is less spasm of the colon, and there are tumor masses that can be identified by CT. As I have said, these are the extra-intestinal manifestations of ulcerative colitis, including fatty liver, gallstones, sclerosing cholangitis, bile duct carcinoma, amyloidosis, urinary tract stones, migratory arthritis, ankylosing spondylitis, and erythema nodosa. The complications of ulcerative colitis include, one of the famous complications is toxic megacolon, I will mention in a moment. Increased risk of developing carcinoma of the colon. Ulcerative colitis is one of the predisposing factors for carcinoma, and in patients with ulcerative colitis you may get multiple carcinomas in the colon, and of course strictures in the colon are also seen together with perforation. This toxic megacolon meaning that the colon is extensively dilated. Particularly, this disease affects the transverse colon, and the colonic wall is very friable and is liable to rupture. Then if you look to the plain x-ray, of course the barium enema and the endoscopy are absolutely contraindicated in such conditions for the fear of perforation of the colon. And you see severe distension of the transverse colon, as you can see in this plain film. A spontaneous perforation of this toxic megacolon may result in 50% of the cases, and the mortality rate is high, may reach about 20 to 30% of patients. The criteria of diagnosis of toxic megacolon is the dilated transverse colon of a caliber more than 6 centimeter. Some of the literature say 9 centimeter, but 6 is good. And the dilatation should be accompanied by one of the or three of the followings, like increase of the temperature, increase of the heart rate, leukocytosis, and anemia with the hematocrit less than 60. Then one of the following items, like dehydration and altered mentation, may be also seen in these patients. And you see here, this is the transverse colon, which is markedly dilated, and this is a sagittal reconstructed image of the abdomen, showing considerable dilatation of the transverse colon. Then we came to the Crohn's disease, and this disease is more common in the small bowel, but it can affect the colon, and this is the incidence. About 10 to 15% of the cases with Crohn's disease may affect the colon. These are the complications of Crohn's disease anywhere, like hemorrhage, obstruction, perforation, abscess formation, fistula tract, toxic megacolon, and the marked increase of the risk of carcinoma in compared to the general population. The Crohn's disease in the colon may result in this particular picture, which is the development of mucosal ulcers and inflammatory pseudopolyps. One of the common causes of pseudopolyps in the colon and in the small bowel is the Crohn's disease. This is the terminal ileum, which is markedly attenuated in the caliber, and you see the transverse colon with coarse appearance of the mucosa, resulting in sorry, this is the appendix, which is affected by the Crohn's disease, and this is part of the colon, which shows the classic prominence of the mucosa. Then Crohn's disease is usually affects the ascending colon, and you can see the appearance of multiple filling defects representing the pseudopolyps, as well as the significant narrowing of the bowel lumen. Strictures may also seen in the Crohn's disease of the small and large bowel, and this is the female patient with positive history of Crohn's disease, and the colonoscopy suggested the presence of a stricture, and the suggestion was confirmed by barium enema, as you can see here. And this patient had performed an ileal transverse anastomosis following excision of the small and part of the large bowel for the treatment of Crohn's disease. And the site of the anastomosis, you see marked the luminal narrowing and the mucosal irregularity, suggesting that the disease has recurred at the site of the anastomosis. And as I have said, ischemic colitis is one of the lesions which produce thumb printing in the colon. And of course, for the diagnosis of ischemia, you need to assess the vascular supply of the colon, and you look for the superior mesenteric and the inferior mesenteric arteries. In cases of ischemia, the rectum is usually spared, and this lesion may affect a significant segment of the colon according to the site of blood supply compromise. The thumb printing is the sequelae of mucosal edema secondary to ischemic changes or compromise of the blood supply. Then the affected segment will be narrowed, and the proximal segments may be dilated. Then this is the classic appearance of a magnified segment of the colon, showing the typical thumb printing appearances due to ischemia. And you remember that thumb printing is seen in other diseases of the colon, like pseudomembranous colitis, but you should remember that for the diagnosis of ischemia, you should have positive clinical and radiological data of compromise of the blood supply. And you remember from ischemic changes in the small bowel that after a time there will be necrosis, and there will be gas in the wall of the affected segment, and this gas may leak into the portal vein, which is one of the bad signs of this ischemic bowel disease. There may be thickening of the wall. There may be gas in the wall of the colon, as you can see, and the thumb printing, as I have said. This is ischemic colitis, and you can see air in the wall of the colon. But you remember that I have said some words about pneumatosis intestinalis, and I mentioned that pneumatosis intestinalis is a non-specific finding, especially if seen in the colon. But in this condition, the presence of signs of ischemia and vascular compromise should raise the possibility of a gangrenous lesion, which is more hazardous compared to the asymptomatic pneumatosis intestinalis. And here is the ischemic changes with gas in the wall of the cecum in a case of ischemic colitis, and the emergency laparotomy found that the cecum was necrotic, and the rest of the right side of the colon looks to be ischemic, and they decided to perform right hemicolectomy. A chronic ischemic changes will result in marked reduction of the caliber of the colon with effacement of the rostral pattern, and you can see that the rest of the colon is good. And this is may help you to differentiate between ischemic colitis and ulcerative colitis. But you should remember that for ischemia you should have positive data of vascular compromise of the colon. Then we came to the benign or the neoplastic lesions of the colon, starting by the benign lesions, and we have a lot of benign polyps in the colon, starting by epithelial polyps like adenoma, tubular vellus and tubular vellus, or the metaplastic polyps, mesodermal polyps like lipoma, leiomyoma, and hemangioma, hamartomatous polyps like those seen in juvenile bulbosis syndromes and Bujuger syndrome, and inflammatory polyps like those pseudopolyps seen in ulcerative colitis, pseudopolyps in Crohn's disease, and in the bilharzial bulbosis of the colon. As a general rule, I have mentioned that pedunculated polyps are usually on the side of benign lesions, while sessile polyps may have the possibility of benign and also malignant possibility. Then you see this is an example of a pedunculated polyp, and this is another one, and you may see a third one here. This is polyps in the colon, and the exact diagnosis will need endoscopy and biopsy. Juvenile polyps are commonly seen in the children, and they are commonly seen in the distal part of the colon, especially the rectum, and they have no risk of malignancy. These are pedunculated polyps, and they are usually treated by endoscopic resection. Also, this is an example of what's known as juvenile bulbosis syndrome, where this is an autosomal dominant disease. You can see too many polyps in the colon of the children. Most of these polyps, or even all of these polyps, are on the hamartomatous side, and they do not have the risk of malignancy. And solitary polyps are seen in about 70% of the cases, but polyps may be multiple. Most of the polyps are located in the rectosigmoid area, 80% of the cases, and the polyps range from 1 millimeter to several centimeters. Then you remember Bujuger syndrome, which is a familial disorder entailing the presence of too many polyps along the gastrointestinal tract, commonly in the small bowel. And one of the diagnostic criteria is the presence of the classic circumoral and mucosal pigmentation, and also the pigmentation of the fingers and toes. Intestinal polyps are found anywhere, most commonly in the small bowel. This is a reconstructed image showing multiple small bowel polyps, and also seen in the axial CT image as well. Many of the literature say that these polyps are usually on the benign side, but there may be a risk of malignant transposition. An adenomatous polyp is the benign epithelial polyp, and these polyps may turn malignant, and the risk of malignancy will increase with the increase in the size of the polyp itself. These polyps will develop malignancy, especially in the villus type, rather than the tubular lesions. And actually, these polyps may be found incidentally while examining the colon by CT or barium enema, and they are usually asymptomatic. Then you look for this colon, and you can see multiple small polyps scattered throughout the colon. And for the accurate diagnosis, you usually need the help of endoscope and biopsy. Then this Gardner syndrome is one of the colonic or bulbosis syndromes. The polyps here are of the adenomatous type, and it carries the risk of malignancy in 100% of the cases, like the familial bulbosis. This Gardner syndrome have many associations together with the polyps in the colon, like the papillary thyroid carcinoma, carcinoid tumors of the small bowel, parathyroid adenoma, adrenal adenoma or carcinoma, and pituitary adenoma. And some of the osseous abnormalities like osteomas, benign exostosis, bone islands, and periosteal thickening. GIT tumors are include you see these are too many polyps in the near the splenic flexure of the colon. The Gardner syndrome include the presence of colonic polyps in all of the cases, gastric polyps in 60% of the cases, gastric hamartomatous polyps, duodenal polyps, preambulary carcinoma, hepatoblastoma, pancreatic carcinoma, lymphoid hyperplasia of the terminal area. And desmoid tumors are also one of the manifestations of this Gardner syndrome. And you see this is an example with a mass in the transverse colon, which has been proved to be a desmoid tumor. Soft tissue manifestations of Gardner syndrome include skin epidermoid cysts, dermoid tumors, fibroma, lipoma, neurofibroma, and lipofibroma, leiomyoma, mammary fibromatosis, abdominal desmoid tumors, peritoneal fibromas. And these are some of the dental abnormalities also seen in this syndrome, like supernumerary teeth, impacted teeth, odontoma, hypercementosis, and teeth more prone to caries. Cronkite-Canada syndrome is one of the colonic bulbosus syndromes, which is characterized together with the polyps in the colon by alopecia, hyperpigmentation, and atrophy of the nails. These are the findings seen in this particular syndrome together with the colonic polyps. In here is a colonic bulbosus of whatever nature. You see multiple filling defects or small polyps in the descending colon as well as in the transverse colon. As I have said, you need the help of endoscopy for the diagnosis. The inflammatory pseudopolyps are usually seen in ulcerative colitis and in the Crohn's disease. Ulcerative colitis affects mainly the left side of the colon. Crohn's disease affects the right side of the colon, as well as the inflammatory bilharzial polyps. This is the pseudopolyps in ulcerative colitis in the descending colon, and this is bilharzial polyps, which are typically located or confined to the region of the rectosigmoid area. And you see here, this is the sigmoid colon, where you can see multiple filling defects representing polyps, and the positive history of bilharziasis is very important. And you also see that the sigmoid colon is displaced outside of the pelvis because of the let us say common finding of the presence of an abscess in the pelvis displacing the sigmoid colon. This is another case. And you see multiple small polyps in the region of the sigmoid. The sigmoid colon is elevated outside the pelvis by a large pericolic bilharzial abscess. Familial bulbosus is an autosomal dominant disease, and in this disease there are too many polyps in the colon by in the early ages, like teens and early 20s of age. And this familial bulbosus is a precancerous condition with 100% risk of malignancy by the age of 30 years. Then if you look for the colon and you see too many polyps scattered throughout the colon, and other colons may be seen in the stomach or the duodenum. Also, desmoid tumors may be associated with this particular disease. As I have said, whenever you see many polyps in the colon, and you should have the help of endoscope to verify the nature of this polyps. And this is the case of familial bulbosus. You see by barium enema, and you see by CT scan the presence of polyps in the colon. Then we came to the malignant polyps or polypoid carcinoma of the colon. and this is usually a sessile lesion. You cannot see a pedicle. It appears as a filling defect in the barium enema, and it may be associated with significant thickening of the adjacent colonic wall. And you see this is a lesion which is a sessile filling defect in the descending proximal part of the descending colon, with thickening of the related colonic wall. And lymphoma may also be associated with polyps in the colon. And you should remember that for accurate diagnosis of polyps in the colon, you should have the help of endoscopic biopsy to confirm the nature of these polyps. And you see here that the colonic wall is significantly thickened, and you also see that there is prominence of the mucosal folds affecting the colon as well as some of the intestinal loops. And this condition, you may feel that you are dealing with pseudomembranous colitis, but the positive history is important. Look for the huge enlargement of the spleen, which is commonly seen with in patients with lymphoma. Colonic cancer is the most common GIT cancer, and is the second most frequent malignancy in adults, and the newly discovered cases account for 15%. This cancer is accounts for 15% of all newly diagnosed carcinomas. The age is usually old, and about 98% of colonic cancer are of the adenocarcinoma type. There are a lot of risk factors, and this is one of the important risk factors, which is the high fat and animal protein diet. Also, the low fiber diet, the obesity, asbestos worker, chronic adenomas, familial bulbosis, blood sugar, and family history of colonic tumors, inflammatory bowel diseases like ulcer colitis and Crohn's disease, lymphoid hyperplasia, and pelvic irradiation, and also some of the surgical procedures. The clinical presentation usually by altered bowel habit, iron deficiency anemia due to occult blood loss, and bowel obstruction if the tumor is large. Intussusception, the tumor will act as a leading point for the intussusception, and maybe massive bleeding, and sometimes the presentation is by metastasis. The typical or the classic appearance of the colonic cancer is the stricture type, which is classically referred to as the apple core configuration. And you see here, this is the transverse colon, and you see the classic apple core configuration due to significant infiltration of the wall of the colon by the tumor, leaving this very narrow lumen of the narrow track of the lumen. The colonic cancer is common in the rectosigmoid area, less common in the cecum and the ascending colon, and less common in the transverse and descending colon. Then this is the configuration of the apple core. You see this green represents the tumor tissue, and this purple will represent the residual lumen left from the carcinoma. And here is the typical apple core configuration in the sigmoid colon by air and by barium in a double contrast barium study. Classic appearance of apple core configuration in the ascending colon. This is the cecum, and this is the ascending colon, representing colonic carcinoma. And this may be also identified by CT scan. And you see, this is the region of the terminal ileum, and this is the region of the cecum, and you got proximal small bowel obstruction with multiple air fluid levels. Of course, you may mistake this appearance for typhlitis or even inflammatory conditions, but the clinical data and further evaluation by endoscopy is very important. Then this is the mass in the region of the cecum, and if you look carefully for the liver and you see a deposit here, this is colonic cancer of the ascending colon associated with metastatic deposit in the liver. And this is the CT scan of a carcinoma in the sigmoid colon. You see the lumen of the colon is severely narrowed, the wall is markedly thickened, and you see this is the urinary bladder, and multiple or small air loculi in the anterior aspect of the bladder, indicating that there should be a fistula between this carcinoma and the urinary bladder. And you may see this fistula also by barium. Sometimes it's better seen by CT scan, and you see barium is going outside the colon into the region of the urinary bladder. This is a carcinoma of the cecum, and you see a big mass infiltrating the cecum, compromising the lumen. Some of the books say that carcinoma is usually responsible for fat stranding of the area around the affected segment of the colon more than inflammatory conditions, but I didn't see that in the clinical practice. I usually feel that inflammation is more responsible for fat stranding than carcinomas. Then if you look here and you see this structure or apple core configuration in the rectosigmoid area with proximal distension of the colon as well as the small bowel. This is an obstructive carcinoma in the region of the sigmoid. Also, you can use the virtual endoscopy and the coronal reformatted images after injection of air into the colon, and you can see this narrowed segment of the transverse colon, and can be seen here in this colonography image. You see the typical apple core configuration in the transverse colon. Then conditions, and this is collected from the internet, conditions that may cause colonic strictures, and they usually start by the letter I. Infiltration by primary or secondary malignancies, ischemia or irradiation, infestation, inflammation like diverticulitis and inflammatory bowel disease, and infection like TB and lymphogranuloma venereum. Then finally, we are discussing the issue of volvulus, and the volvulus of the colon usually affects the sigmoid and the cecum. And the most common, they are considered the most common types of volvulus all over the gastrointestinal tract. However, you remember that volvulus may affect the stomach, as we have been discussed in the subject of the gastric imaging, and sometimes you got volvulus of the small bowel. I will discuss this once more in the cases of peritoneal imaging, and this volvulus may result in complete or partial obstruction and may lead to compromise of the blood supply, resulting in ischemia and gangrene, hence perforation and too many complications. This sigmoid volvulus is the most common volvulus at all in the gastrointestinal tract, and it is responsible for 8% of intestinal obstructive changes, and commonly seen in neurologically impaired persons who are old in age, with the risk of mortality reaching 20 to 25% of cases. These are the predisposing factors: chronic constipation, high rough diet, mobile sigmoid colon, roundworm infestation, and megacolon, often due to Shake's disease, for example. Then the age incidence of this sigmoid volvulus is around 50 years, and sometimes it may be seen in the children, and as I have mentioned, the mortality rate is about 20 to 25% of the cases. The colon is torsion of the colon will result in luminal obstruction in 180-degree torsion, and venous occlusion in 360 degrees of torsion, which will be followed by gangrene and perforation. I have to say that the plain film is the most reliable imaging technique for diagnosis of volvulus of the sigmoid and also the volvulus of the cecum. The symptoms of sigmoid volvulus include acute abdominal distension, colicky pain in the left lower quadrant, failure to pass flatus or stool or stools, and vomiting is a late sign. Respiratory and cardiac function compromise, and these symptoms are almost absent in patients who are bedridden. Then a reliable diagnosis is based on the dilatation of the two loops of the sigmoid colon, giving the appearance of bent inner tube or inverted U or the coffee bean sign. Then the dilated colon usually point to the right upper quadrant, but actually you don't need this pointing for the diagnosis. If you see the region of the sigmoid is usually dilated and it looks like the inverted U configuration, then the diagnosis is easy. And this is what we call the coffee bean sign, and it's almost typical to the appearance of the coffee bean. This is the sigmoid colon, the pentatube appearance, and the pointing to the upper quadrant, right upper quadrant are evident. And this is also looks like the coffee bean sign with huge distension of the sigmoid colon and the inverted U configuration. If you inject barium, you will go to the bird's beak sign or the parrot beak sign. The barium will stop at the site of volvulus, giving this characteristic beak. And this is the typical appearance of sigmoid volvulus by plain film, which is enough for the diagnosis. And this is the parrot beak configuration after injecting barium. Then finally we came to the cecal volvulus, and the cecal volvulus is seen in relatively younger age, and this is the age incidence from 30 to 60 years, and compared to those with sigmoid volvulus. The predisposing factors are hypermobility of the right side of the colon and pelvic masses, postoperative adhesions, pregnancy, and recent colonoscopy. Then the diagnosis is also easily made from the plain film by identifying the huge dilatation of the cecum, whether pointing to the left upper quadrant or anywhere. The clinical findings include gradual onset of acute cramping, pain, distension, constipation, and vomiting. Then the small bowel obstruction, ischemia, and perforation as seen in sigmoid volvulus. This is the radiographic appearance with the hugely distended cecum with air, and this is located anywhere in the abdomen, but commonly in the right side, and the air fluid level may be seen in the small bowel secondary to obstruction. This is the classic appearance, plain film finding of sigmoid volvulus in a teen years old male with abdominal distension, showing the severe distension of the cecum. Then as I have said, the abdominal films, plain films, are usually diagnostic. The largest dilated loop corresponds to the site of the volvulus. If it is the cecum, this is the cecum. If it is the sigmoid, this is the sigmoid. Loss of ostra, the cecal volvulus, the bowel loops will point to the left upper quadrant. Whatever this pointing, and you can easily appreciate the site of dilatation. هذا وبالله التوفيق والحمد لله رب العالمين.